Hi, good morning, everyone. Today we are going to talk about hypertriglyceridemia and in adults and its approach to evaluation. Today it's only evaluation we are going to talk about. The rest of the treatment part that will be discussed in the next session. Starting with classification. Before that, I would like to tell you something about a few sentences about the general lipid metabolism. As we all know, we have all the various fractions of lipids, triglycerides, total cholesterol, LDL, VLDL, and HDL, and non-HDL. Of apolipoprotein is the most important part we should be knowing before starting this discussion. Basically, in lipoprotein, you have one component that is protein, which is the apolipoprotein. The protein part of the lipoprotein is the apolipoprotein, and the other one is anyway the lipid component, which could be HDL, LDL, or triglyceride or cholesterol. So in apolipoproteins, we have 5 kinds of that. From A, B, C, D, and E. In A, we have
Rajita, your slide is not moving.
The slides are late, sir. I'm just
okay, right, carry on.
Yeah. So there are 5 kinds of apolipoproteins from A to E. In lipoprotein A, we have 3 variants, three kinds, 1, 2, and 4. The first and the 2, the 1 and the 2 both are the structural proteins for HDL. And A4, the apolipoprotein A4 is activator of lipoprotein lipase and L-carnitine acyltransferase. That is the first lipoprotein A, A1, A2, and A4. The next is lipoprotein B. In B, we have 2 kinds, B100 and B48. B100 is again the structural protein for VLDL. A is the structural protein for HDL, B is the structural protein for VLDL, and B48 is a truncated form of B100, which is contains about 48% of the B100. Then we have C, apolipoprotein C, which is again we have 3 variants of it. The most important component is C2, which is an essential cofactor for lipoprotein lipase. And D is not of much importance. Apolipoprotein E is again is a ligand for hepatic chylomicrons and VLDL remnant receptor. So this is responsible for clearance of these lipoproteins from the circulation. That is, chylomicrons and VLDL remnants are removed by removal is caused by apolipoprotein E. So these are the apolipoproteins, 5 kinds. Then talking about classification. In classification, according to the triglyceride levels, we have 3 kinds. The normal, we all know, the normal triglyceride level is less than 150 milligrams per deciliter. Starting from moderate, it is 150 to 499 milligrams per deciliter is moderate. With 500 to 999 milligrams per deciliter is moderate to severe, and severe is anything more than 1000. So we can convert this milligrams per deciliter into millimoles per liter by dividing milligrams per deciliter value by 88.5. So that completes the classification of triglycerides. The next one is we are talking about classification of lipid disorders. According to the typical lipid levels we see in a report, and the associated lipoprotein abnormality. The classification is based on this associated lipoprotein abnormality and the kind of lipid level we are seeing associated raise. This is a Frederick classification. They have 5 types of lipid disorders, and this type 2 is the only one which is divided into A and B. All the others are single. So type 1 is associated with lipoprotein abnormality of chylomicrons. Triglycerides are about 99 percentile. And type 2A is associated with LDL lipoprotein abnormality, with total cholesterol being more than 90th centile and with ApoB being more than 90th centile. The same is almost true with type 2B with LDL and VLDL lipoprotein abnormality. And type 3 is you have remnants of VLDL and chylomicrons. This is the lipoprotein abnormality associated. Both again type 2 total cholesterol and triglycerides more than 90th centile. Type 4 is associated with VLDL lipoprotein abnormality. Again, its total cholesterol is more than 90th centile, and triglycerides is again more than 90th centile. Type 5 is associated with chylomicrons and VLDL. Triglycerides are more than 90th centile. So this is the classification of lipid disorders from 1 to 5. The next is etiology. Of course, we first thing we have to talk about is etiology in this disorder. In most patients with elevated triglyceride levels, we have both primary and secondary disorders coexisting. It's not just one thing that is present in these patients. It's a combination of both primary and secondary, that is genetic and acquired causes are present, disorders are present. HyperTRIGLYCERIDEMIA is usually an imbalance in the production of triglyceride-rich lipoproteins from liver. VLDL, you have two kinds of TG-rich lipoproteins being produced in our body. One is VLDL that is produced from liver, and the other is chylomicrons, which is from intestines. So because of the excess production of one VLDL from liver, that second one is chylomicrons from intestine, and the reduction in the lipolytic removal of TG from both these lipoproteins. So these three factors are contributing to hypertriglyceridemia. And chylomicron, as already told, chylomicron production reflects dietary fat intake. Most lipolysis of circulating TG-rich lipoproteins is mediated by lipoprotein lipase. As we all know, lipoprotein lipase enzyme is responsible for the clearance of triglycerides from the lipoproteins. Nearly all patients with severe hypertriglyceridemia have a genetic predisposition plus an additional cofactor. As we already know, it's a combination of primary and secondary, genetic and acquired. So along with the genetic factor, we have predisposition, we have an acquired disorder also, usually diabetes, alcohol abuse, or an estrogen therapy. There are just a few examples that I mentioned here that lead to saturation kinetics of lipoprotein lipase. So as already told, LPL mediates lipolysis of triglyceride and triglyceride-rich lipoproteins, that is chylomicrons and VLDL. So there's overproduction of VLDL, chylomicrons, and a lack of clearance of these two particles, which leads to hypertriglyceridemia. Next is, anyway, we have the genetic factors are very varied. They have told many umpteen things which I haven't been able to discuss here. They even gave a very large classification, which seems not really possible to discuss here. So the genetic factors includes both polygenic and monogenic, polygenic factors and monogenic syndromes. Here, acquired factors, we'll discuss about acquired factors here. And acquired factors, insulin resistance is the first thing, is the most important one, which results in hypertriglyceridemia, as we all know. Obesity, metabolic syndrome, type 2 diabetes, pregnancy, chronic renal failure, HIV, hepatocellular disease, chronic inflammatory disease. All these conditions are associated with insulin resistance. So in insulin resistance, the primary pathology is the increase in free fatty acid delivery from adipose tissue to the liver, and there's overproduction of the triglyceride-rich VLDL particles with variable defect in clearance of this VLDL, the triglyceride-rich lipoprotein, because of the reduced activity of lipoprotein lipase. So there's overproduction as well as lack of clearance by LPL, which is causing hypertriglyceridemia and insulin resistance syndromes. Next is renal disease. In renal disease, you have proteinuria, uremia, or glomerulonephritis. As we all know, in nephrotic syndrome, there is excess amount of loss of cholesterol in urine, which leads to liver causing overproduction of both lipoproteins as well as cholesterol. So this leads to hypertriglyceridemia and hypercholesterolemia. Both are associated. And then the most common condition we see clinically, hypothyroidism, is associated with hypertriglyceridemia. Then, and of course, what we eat, diet with excess calories, excess amount of glycemic load, and and of course fat intake is also contributes to hypertriglyceridemia. And then alcohol consumption. The threshold for females is 1 drink per day, and for males it is 2 drinks per day. Then, yeah, medications. This is the most important thing we should be knowing. Thiazide diuretics, which is used very commonly, is one of the cause of hypertriglyceridemia, and again beta blockers also. Bile acid sequestrants, antiretroviral agents used especially for HIV. Then second generation antipsychotic medications like clozapine and olanzapine, they are also associated with hypertriglyceridemia, and therefore all those patients who are taking antipsychotic medications are actually should be evaluated baseline for lipid profile should be evaluated initially, and then only be started on these medications. Next is certain antineoplastic agents like cyclophosphamines, elastogenase, and immunosuppressants. Oral estrogens, hormones, female hormone is very important. So all those patients who are going to be started on HRT or any replacement therapy, all those are definitely predisposed to this. So they should be evaluated. Monitoring should be definitely going on for these patients. Next is the selective estrogen receptor modulators, tamoxifen, raloxifene, and clomiphene. These also predispose to hypertriglyceridemia. Then retinoic acid derivatives, isotretinoin, acetretin, bexarotene. All these are used in acne vulgaris patients, especially severe acne. So they should be first, baseline evaluation should be there so that you don't start the drug for patients who are already having some bad lipid levels. As already told, genetic factors include both polygenic and monogenic, which I haven't been able to discuss here. Next is clinical manifestations. Clinical manifestations, we don't really have too many symptoms or signs, but a few have been told here. Xanthomas. Some patients with moderate or severe hypertriglyceridemia do have xanthomas, which is which I haven't been able to see too much. I hope some of you have seen this. I would like to share a few pictures here. And the type of xanthoma varies according to the lipoprotein disorder that is associated. So,
what happened? Why there is so much of silence?
I'm trying to share the pictures of xanthomas, sir.
Okay. Continue talking.
Oh, yeah. So we have various kinds of xanthomas, eruptive xanthomas, tuberous, and yeah, I hope you can see this picture. Yeah, these are eruptive xanthomas, which were multiple yellow red papules, and this is the second example. Yeah. So these are all the pictures of eruptive xanthomas. We could probably just confuse it with any other dermatological manifestation, but we probably need to give a very to diagnose if this is actually a xanthoma. So these are eruptive xanthomas. And next
टाइम आज बहुत ही कैजुअल कर रहे 10 मिनट पहले खाते रहे तो क्या हो जाता नुकसान होता
Yeah, these are multiple nodules on the knee. These are tuberous xanthomas. This is next one, which is on the elbow. Tuberous xanthomas, as the name suggests, it is on the tuberosity, tuberosity. This is on the elbow. That was on the first one was on the knee, and this is again in yellow papules on the elbow in the case of a tuberous xanthoma. These are tendinous xanthomas present on the dorsum of the hands. This is Xanthelasma. I think we do see this very commonly, especially senile patients. Then these are xanthelasmas, yellow plaques beneath the mandible. This is a plain xanthoma. Then surrounding the axilla, verruciform xanthoma, which is a solitary papilla on the scrotum. Then, yeah, so this is the xanthoma. These are the various kinds of xanthomas we see. But according to the Frederick classification, which was initially discussed, the 5 types of lipid disorders, the xanthomas observed in each of these lipoprotein abnormalities is different. Type 1, you have eruptive xanthomas, and type 5, type 4, type 5, and type 1. All these 3 are associated with eruptive xanthomas. And in type 2A and type 2B, you have tuberous xanthomas, which is more common. And in type 3, you have tuber-eruptive and plain xanthomas of the palmar creases. So these are the most common associated xanthomas in each of these 5 types of disorders. The next is chylomicronemia syndrome. Patients with severe hypertriglyceridemia develop chylomicronemia syndrome, which is associated with the following clinical manifestations: short-term memory loss, hepatosplenomegaly, abdominal pain, pancreatitis, dyspnea, flushing with alcohol, lipemia retinalis, and xanthomas. Then these are just a few pictures. This is the appearance of blood specimen. The appearance of an overnight refrigerated plasma sample can suggest which of the component of the lipoprotein is in excess, whether it's a VLDL, chylomicron, or both of them. While chylomicron part forms the supernatant, the BL parts forms this important part of the overnight refrigerated plasma sample. So as you can see in this picture, monogenic chylomicronemia syndrome, commonly known as type 1 hyperlipoproteinemia, the supernatant appears creamy due to chylomicrons, and the infranatant is clear, whereas in type 1 hyperlipoproteinemia, with both chylomicrons and VLDL being in excess, the supernatant is milky, whereas because of chylomicrons in excess, and infranatant is cloudy due to VLDL particles. And yeah, so this was a few clinical manifestations and what you see and lab-wise when you are refrigerating the blood sample. Talking about the lipid profile, LDL cholesterol, the other components should also be looked into when you are looking at the lipid profile of a hypertriglyceridemia patient. LDL cholesterol is usually elevated. Most patients with hypertriglyceridemia have elevated serum LDL concentrations with the corresponding high ApoB levels, which is already discussed. This is lipoprotein associated with LDL, and high triglyceride levels are associated with small, dense cholesterol depleted LDL particles. We often see that any lipid report with excess with more than 500 milligrams per deciliter of triglycerides doesn't show LDL cholesterol. It is shown as blank. This is because of this reason. Whenever triglyceride levels are very high, LDL cholesterol is not measured. The analyzer fails to analyze the LDL particles, and therefore it is shown as blank. LDL cholesterol levels was underrepresent cardiovascular risk in this population. The next is non-HDL cholesterol and ApoB. In patients with hypertriglyceridemia, non-HDL and ApoB levels both are elevated. There are better measures of excess concentration of atherogenic lipoproteins than LDL cholesterol in patients with hypertriglyceridemia. And in most patients with hypertriglyceridemia have low levels of HDL-C, HDL cholesterol. This is because lipoprotein lipase is important in the generation of HDL particles. Because usually HDL, the core of the HDL is made up of cholesterol ester, but because of high amounts of triglyceride levels, the HDL core is more of made of is completely TG triglyceride enriched, and therefore this is catabolized by lipoprotein lipase very rapidly, and therefore the associated with hypertriglyceridemia, what we generally see is low level of HDLC. Then, so changes in plasma triglycerides and HDL cholesterol levels are generally inversely related, except in the following conditions. In moderate alcohol consumption, both triglycerides and HDL cholesterol levels increase. In sex steroid hormones, like in oral estrogen intake, both components are raised. In active weight loss, both are decreased. And in thyroid disease, both may increase.